Hello everyone, my name is Dr. Fred Arthur. I'm a family physician in London, Canada at Western University. I hope this video will assist with discussions around the concept of a mental model. I think it's most useful to look at it what I call a cognitive box diagram, and the concept of a box is a very useful analogy because boxes have walls. So the walls of our mental model are constrained and created by the fundamental presuppositions that we have. So we believe, for instance, that solid tumors occur by genetic evolution within the tumor, which generates more anaplastic clones, which then can damage the tissue and then create the ability to spread to other tissues. There are many other possibilities for these phenomena that we observe, but that is our present mental model based on the presuppositions that we have. This mental model is then expressed by our clinical behaviors and provides the full motivation for our behaviors. So the diagnostic categorization procedures that we use, the therapeutic processes that we do, and the outcome evaluations that we make of the patient are usually provided by the mental model. The evidence for the mental model is actually fairly extensive. It has an impressive empirical foundation, and most of these studies are historical analytical studies which are produced in single text by really a wide group of scientific writers. The problem with this genre is that it really hasn't made it into the medical evidence world. So these are not randomized controlled trials. These type of studies will not make it into the hierarchy of evidence. However, they provide really important arguments and evidence to support different field concepts, including the mental model concept. There are numerous writers. I've listed a few here, but really the list is quite large and they come from many different fields in science. I think it's quite helpful to look at the mental model entry and exit in order to understand the process. So again, what we are trying to learn is what happens in the creation of a mental model, and we also want to learn how this can create error and bias within our research studies. So in the real world, there's a population of people. They are not subcategorized, and they have a natural development of all symptoms and mortality, so that at T+1, you now have a new population which is experiencing symptoms and has decreased in size due to mortality. What happens in medicine, though, is we use theoretical worlds. So the subcategorization of this population occurs via the diagnostic process. So we use a PSA, for instance, in prostate cancer. We then biopsy positive PSA patients, and from the biopsy and the pathology, we end up with grade and stage categorizations. So we've taken a group of people out of the large population, and these are now our cancer patients which exist within the theoretical world. Due to the staging that we have, we then match that with various therapies that are provided and motivated by the mental model. At the end of that process, we now have at T+1 a population of patients who are experiencing symptoms and have a given mortality rate. So we may look at such mental model outcomes as the size of the tumor, the length of time the patient survives with a tumor, the amount of metastasis, things of that nature, but these outcomes are mental model outcomes. We have to leave the mental model and return to the real world before we can really evaluate this mental model in terms of its value to the patients. So these patients, again, only experience symptoms and mortality. They don't experience the growth of the tumor, and therefore the key end outcome has to be all-cause morbidity and mortality. The problem with mental models is that they encourage circular reasoning. Circular reasoning allows the model to motivate the continued use of itself. So it evaluates itself, which of course is a logical flaw. In order to see how this occurs, we first of all remove the real world outcomes. We then create a structure wherein we have a circularity so that the outcomes, which are model-based, are then used to motivate the continued use of model-based therapies and model-based diagnostic procedures. Thank you.